ఇదేనా? పెద్దగా ఏం కాదు. ఓకే, థ్యాంక్ యూ. Okay, actually I was to start hernia. Good morning everybody. It's been quite some time that I spoke to you guys, at least the final years. I was to start hernia, but unfortunately I couldn't make it to on this Saturday. So Dr. Prabhu will be continuing your hernia class come next whenever it's feasible. Today I'm going to start with arterial disease. Basically the whole of the vascular system I should be continuing. So initially it will be arteries, followed by veins, and then lymphatics. Lymphatics I'll not take a huge set of classes, probably one class should finish off whole of the lymphatics. Arterial system will take 2 classes, and venous system also would take 2 classes, depending on how we are continuing. And today I'm going to start with arterial system. At the initial thing, you have to understand what exactly is an artery. How do you define an artery? Most of you are in the view that anything that carries pure blood is artery. No, it is not that. Pulmonary arteries carry impure blood, they don't carry pure blood. So that particular statement is usually wrong. Artery or arteries are defined as in simple word, any structure that carries blood away from the heart is basically called an artery. You should be remembering this, because this is an entrance bit long ago asked, and after which most of the times it's now not asked. So I'm not telling that you will be asked about it, but in a viva, if anybody is interested, they would definitely ask you, how do you define an artery? And if you say artery carries pure blood, you're wrong. No, it does not carry pure blood always. Artery is anything that carries blood away from the heart. Even pulmonary artery will carry blood from the heart to the lungs for purification. And of course, arterial blood is how arteries go, aorta, ascending aorta, descending aorta, and all. So you have to understand that arteries are anything that carries blood away from the heart. So in artery, it's basically occlusive diseases that we are worried about. There could be multiple occlusive diseases and multiple occlusive disorders. In between, there are certain terms that we have to be discussing in detail, because they are useful for you in the entrance point of view as well as in your theory point of view. There is so you should remember, arteries are arterial system, not arteries. Arterial system is something that you should be concentrating definitely. Why? Because there's always a long case or a short question coming in the exam theory. In practical exam, if we have a Burgess disease or an atherosclerotic gangrene, dry gangrene, it will be kept in the exam for sure. And all those who are planning to become postgraduates in general surgery, you should remember that it is a long case for you even in the final exam of MS. So arterial disease and venous disease you should know in and out in detail, because either varicose veins or an arterial disease is compulsory, is a must and should question in your entrance paper. These are high yielding topics. Definitely one question will definitely come from these 2 topics. In the vast topics of whole of surgery, you will have a definite question coming to you from either the arterial system or the venous system. Basically, it would take exactly 1/2 day for you to finish off it in total. So I'll try to make things simpler. I'll try to cover some of the important entrance points, also theoretical points, as well as viva questions, because anyhow it's going to be a long case for you in this particular segment. So first of all, you should know what exactly is the problem with the arterial system. Arterial system, because usually, except for the pulmonary arteries, will carry pure blood, and all the tissues need perfusion, that is oxygen, as well as the energy requirements coming from the arteries. So it carries the glucose also. So this just does not carry your oxygen, it also carries the desired food or ATP, whatever, to your tissues. So you should remember that when arteries are blocked, it's going to be lack of nourishment as well as lack of perfusion. So arterial occlusion is basically of two varieties. One is early and one is late. Okay, and what exactly are these occlusions? Which definitive occlusions are most common. Please remember, the most common cause of arterial occlusion is atherosclerosis. Atherosclerosis is the single most common cause of arterial occlusion, followed by Burgess disease. There are other varieties, that is vasculitis, Takayasu arteritis, polyarteritis nodosa, systemic lupus erythematosus, radiation exposure. All these cause arterial occlusion. And then there are certain rare varieties of occlusions of the arteries, that is entrapment. Most probably it is called as entrapment, and this is compression, external thoracic outlet compression, popliteal entrapment, thoracic outlet obstruction, and retroperitoneal fibrosis. These are the other conditions, though they are rare, but also cause arterial occlusion. Now you should know each of it. How does it work? Okay, when at a certain point, if the arterial blockage is there, most of the times it's the lower limbs that we are discussing about, and you should know if a segment of artery is involved, what are the symptoms that you're going to get. Of course, we will be discussing the detailed symptomatology as well as signs in the course of time, but you should know exactly this, because all these 5 points are previously asked in the entrance papers, so you should know. So first, if it is a ioto-ilio bypass, if it is ioto, descending aorta, iliac arteries bypass, at that part of time, if there is a blockage, how the patient should present? How will the patient present to you? The patient will present to you with buttock claudication. This is more important. Then thigh, buttock, thigh, and the calves. All the 3 systems are involved. And then, if it is femoral block, then the patient will have pain, claudication in the thigh as well as the calves. And if it is popliteal, crural, as well as popliteal, crural, and superficial femoral, the occlusion will only cause pain in the calves. So when it is ioto-iliac, it is the buttocks, it is the thigh as well as the lower calves. Whereas if it is femoral, that is common femoral, you will have pain or claudication at thigh as well as the lower limb, that is calves. And if it is superficial femoral, if it is crural, as well as if it is popliteal, you will have pain coming at, or the claudication coming at, only the calves. If it is ilio-ioto bypass, patient will have something called as impotence. And when you see atherosclerosis comes to the people who are almost in the 6th to 7th decades. Burgess disease, which is another common disease, which I'll be discussing in detail later, is the disease of young, that is 3rd and 4th decade, usually 3rd and 4th decade. And this particular Burgess disease is an exclusive disease, please keep it in mind, exclusive disease of men. And both atherosclerotic type of arterial occlusion as well as Burgess type of arterial occlusion is totally different. Atherosclerotic can come to the smallest of the possible vessel to the largest of the vessel, and Burgess disease is only for the smallest and the small and the medium sized arteries. And of course I'll be discussing about Burgess later, but this is what is the difference. They're not atherosclerotic process. Burgess disease is a vasculitic process, as well, and atherosclerosis is a bodily change. You have to remember this. Okay, after which we will come to embolus. If you have an emboli, what are the symptoms or the patient will present to you with? If the embolus is there in the femoral artery, you will, or any of the vessels in the lower limb, how will the symptoms be? Symptoms will be excruciating pain, change in the color. This is the symptoms, and the signs is the patient will have pulselessness, hyperemia, gangrenous change. These are the things that you find when the artery gets occluded off the lower limbs, either the femoral or the popliteal or anything. And then if it is mesenteric ischemia, supposedly mesenteric ischemia, that segment of the bowel loop will become gangrenous, which means the patient will present to you with peritonitis, that is distension of abdomen, pain abdomen. He won't allow you to touch him, that is guarding and rigidity. If gangrene sets in, the patient will go into shock, because bowel is very sensitive to hypoxia, very sensitive to hypoxia. So you should remember that mesenteric ischemia is a surgical emergency, and the tolerating capacity is up to 4 to 6 hours, not beyond. 4 hours is the maximum. 4 to 6 hours is maximum for the lower limbs also, but the digits, yes, please remember the digits can survive up to 8 to 12 hours of occlusion. If the embolus has gone and obstructed the carotids or the vertebral arteries, how are you going to, what is the symptoms that you get? Most of the times it is a transient ischemic attack or a cerebrovascular attack. If it goes and occludes an artery in your heart, what does it cause? It causes myocardial ischemia. And what else? If it is I said brain, I said this. Okay, if it is spleen, there will be a pain in the left hypochondrium, and if it is in the kidney, you will have pain in the loins with hematuria. Please remember, it should be hematuria. The patient should present with hematuria and pain in the loins when you have occluded renal arteries, and all by an embolus. You please remember, it's by an embolus. How will the embolus form? That's altogether a different topic. Embolus is formed how? Initially, a segment of artery gets, there is a damage to your endothelium. It is the endothelial damage that starts producing a thrombus. Okay, the blood leaks from the blood vessel, because the blood vessel, whatever the arterial supply to the blood vessel is there. Once the intima is broken, the blood starts flowing out, and this blood, as it's coming and it's staying there, what does the body do? The body will allow the platelets to go and accumulate. As the platelets go and accumulate to arrest the bleed from the blood vessels, it forms a clot. This clot, it stays there for some time. It can dislodge immediately, but very small, so unlikely. But if it's continuous atherosclerotic process, continuous damage of the intima followed by collection of this with the platelets, and that vessels, and they are there you have the LDL and VLDL cholesterol getting and accumulating in that particular formed clot, and they get organized. This organized clot will ulcerate with the proliferation of the smooth muscle cells, and that ulcerated part will lead to formation of a thrombus, and this thrombus is so hard to feel, but it is actually very fragile, so it will just dislodge with a high pressure of blood. How will the high pressure come? Because this thrombus is occluding a segment, the blood flow to that particular part needs to push the blood at a faster and a speed with which it should send, so that this blood that is coming should flow far. So that is not happening. So immediately, with the pressure that puts the blood puts on that particular thrombus, it dislodges and goes and occludes some other place. Okay, if it is occluding your heart, it causes myocardial infarction. If it is occluding the carotids, it is causing a cerebrovascular attack. If it is mesentery, it is causing mesenteric ischemia. It could be acute or chronic. Then if it is occluding the kidney, that is renal blood vessels, the patient is having lion pain with hematuria. If it is occluding the spleen, splenic infarction will cause microthrombi, and you'll have pain in the left hypochondrium. And if it is occluding the lower limb, I said pain, paresthesia, pulselessness. This is what the patient feels. So you have to understand that occlusion of arteries is an emergency. Acute is an emergency. Chronic is a semi-emergency. Because if you think chronic is a chronic process, why are we so bothered? Over a period of time, the patient will end up with gangrene of that particular segment. And when gangrene sets in, there's no other option but you have to perform something called as an amputation. Doing an amputation is never a choice to the surgeon or anybody for that matter. Please remember, no surgeon wants to amputate a limb. It's the patient's choice at the end of the day. To save the patient, we end up doing amputation. So you should be more careful about acute occlusion or chronic occlusion. Chronic occlusion even more, because it is giving you the time to treat the patient properly. But there is one damn disease that is called as Burgess disease, which I'll be discussing later, will not give you the chance. Even if it is chronic, you probably end up doing the patient an amputation because it is segmental. I'll be talking about it in the later time that is coming. Okay, in the time that comes now, I'll be discussing about this. Then atherosclerosis comes to the people who are in the age group of 60-70. That is I'm now properly talking about atherosclerosis. And atherosclerosis, how does atherosclerosis start taking place? Atherosclerosis start taking place in the aged because of, yes, the body's composure is changing. They're not exercising anymore in the 60-70. Even if they're exercising, they're limited. Their exercise is limited. So what is happening? Their eating habits have slowed. They're probably not eating what healthy food they used to once upon a time eat. So what happens? There is a mismatch in the HDL and the LDL-VLDL cholesterol, which is maintained, balanced, may probably increase and decrease. That is HDL cholesterol decreasing, LDL and VLDL cholesterol increasing. So what does HDL cholesterol do? HDL cholesterol, please remember the word, it reverse transports cholesterol, high density lipoprotein. It reverse transports bad cholesterol from the peripheral circulation to the liver. Whereas LDL, VLDL, these are the cholesterols that are going in the blood and moving around and causing all sorts of damage. So there is a mismatch in the HDL, VLDL cholesterol as the patient ages because of so many other factors. Sometimes it is diabetes, sometimes it is hypertension, sometimes it is because of mismatch. All as other things I said. Age is not a modifiable cause. So you should remember, age itself is a problem. So what happens is the blood vessels, they become thick with cholesterol. So when they become thick with VLDL, LDL cholesterol coating, they will lose the expansality. They don't expand anymore like they previously used to, or when in young people it happens. So as this keeps on going, as this process keeps on going, the pressure, what is blood pressure? It is the lateral pressure exerted by the blood pressure, the blood, flowing blood, lateral pressure exerted by the flowing blood on the vessel wall. That is what is your blood pressure definition. So what is happening is, when this vessel has thickened and the flow of the speed of the blood flow is the same, but it is not expanding to the tune it should expand. So what will your body do? It will want to push it at a speeder rate, and as it does, and the blood vessel is not expanding, your body's pressure, blood pressure is rising. So atherosclerosis itself will cause hypertension, but hypertension progresses atherosclerosis. Diabetes causes how? It is a simple phenomenon. What happens in diabetes is the patient usually the patient has high glucose levels. These glucose levels will not allow the patient high glucose levels, these are not used by the tissue. So what do they do? They become fats. They're getting converted to fats, and most of the times it is chylomicrons, VLDL, LDL than HDL. So this VLDL, LDL, they again increase in them is causing that, as well as they cause microangiopathy. They cause microangiopathy. So that is what is the problem with atherosclerosis. So it forms a triad or a vicious circle that there is no escape. Causing of high blood glucose is causing lipid increase, and that is causing increased atherosclerosis. Hypertension itself is causing thickened blood vessel, again increasing the cholesterol content, and at the same time cholesterol increasing is leading to hypertension, and it all forms a triad, or what you call is a hypertensive crisis most of the times. So you should remember that this vicious circle is the reason why we start the patients on statins as he crosses the age of 60 with or without comorbidities. If it's a diabetic patient, we are starting the patient with telmisartan as well as telmisartan. I mean talking about telmisartan, ARBs. Previously they used to start with AC inhibitors, but unfortunately AC inhibitors produces dry cough. So we are not giving them that kind of ACE inhibitors because the patient is continuously coughing. We are not happy with that. Not we, the patient himself is not happy. We are more than happy to manage the dry cough, but the patient is, because it's very unpleasant, so patient himself wants something else. So we start with small dose ARBs along with ecosprin to keep the blood thinner, because aspirin has got blood thinning property. So we want the blood to be thin, not less. That instead of calling it thin, I should call it as less viscous. We want the blood to be less viscous, because if less viscous the blood is, it will not stick anywhere, it will continuously flow. If it is viscous, it will just try to stand it with the vessel, and when body has a lot of cholesterol is nothing but soap like, so it sticks. We don't want that to happen. So we give the patient, once he crosses the age of 60, if it's a diabetic patient, we start them with ARBs, then we start them with ecosprin. That is, ecosprin is nothing but aspirin in small doses, about 75 milligrams, and then we will start the patient with a statin. Most of the times it is if you are starting with rosuvastatin, you can give 10 milligrams. If you're starting with rosuvastatin, you give 5 milligrams, and if you start with atorvastatin, you probably give 10 milligrams. Rosuvastatin has been proven to be better. So 10 milligrams, 20 milligrams of rosuvastatin is a must if you have any relatives of 60, 65 or 70 years. It is better you start them with ecosprin as well as this. If their blood pressure, telmisartan will add, ARBs will definitely add to its treatment process. So these are the things that we want to prevent by giving it. So atherosclerosis continuously systemizes, and then that will cause damaging. Atherosclerosis will cause damage to all the organs. Please remember, there is nothing that it spares. It does not spare your heart, it does not spare the lung, it does not spare the brain, it does not spare the lower limbs, it does not spare your abdomen, it does not spare your intestines, it does not spare anything. It does not spare anything. Any system can be involved, because it's the large vessels that are getting involved in atherosclerosis, not the small blood vessels. The small blood vessels and the medium blood vessels, I'll be coming in another 5 minutes there. that is Burgess disease. So atherosclerosis has to be prevented. As I said, we give them with statins or this thing. But when these occlude, we will be knowing about them once they start occluding, once we move to the next segments after today's class. Today's class I'll be discussing, next will be Burgess disease for the next half an hour or so, then AVF, and I'll close it for today. And the next class will be thoracic outlet obstruction, then you'll have mesenteric ischemia, I'll be teaching you renal artery stenosis, then if need be, I may or may not touch heart, because you will be extensively learning about it in your general medicine. But yeah, I will not leave it like that, but I'll tell you the process, what is happening. Then we'll now move to one of the most important topics, as well as there is so much to know, so much to learn in this particular topic that is called as Burgess disease, or also known as thromboangiitis obliterans. It is called as segmental inflammatory disease of, also called as segmental inflammatory disease of the small and the medium arteries. Please remember, segmental inflammation of small and medium vessels. It's only the small and the medium vessels, and remember this small and the medium vessels, because this is very, very important. Why? I tell you as we move in the class forward. It has got a strong predilection for smoking, and it is a disease exclusively for men who are smokers. It occurs in the third and fourth decade, that is, the patient is mid-30s and mid-40s or late 40s. So 30 to 50 is the period in which you will get Burgess disease. To all the smokers, this is the problem that they will be facing in the future. And once it starts affecting, it is a disease that it won't stop anywhere. Ultimately, if atherosclerosis is there, there is a chance that we will do bypass. That I'll be talking in ischemia and other things later. But here, there is a chance that we will do bypass. But in Burgess disease, there is no question of bypass. Why? Because it has got segmental disease. There are skip lesions. It's not in general or in total occlusion. There are skip lesions. So if I want to do a segmental bypass to this, once the skip lesion passes, again it's going to become difficult. Yes or no? So there is no chance that you do a aortic bypass for Burgess disease. Ultimately, the Burgess disease patient will request for an amputation. That will be covering what you call as critical limb ischemia or acute limb ischemia is not possible here. That's more of an embolic phenomenon. So what happens in Burgess disease? There is sharply acute on chronic vasculitis happening in the small and medium vessels of the lower limbs or sometimes upper limbs. But sometimes, it's not that it does not happen in upper limbs, but it does happen, but it is rare or unusual for us to expect that this particular thing will happen in the upper limbs. But more likely it is chronic smokers in the age group of 40 to 50. Smoking also is one of the reasons for atherosclerosis also, but that is in the 6th and 7th decade. So there is sharply acute on chronic inflammation or chronic vasculitis of the small and the lower limbs. It does not stop there, because it is a autoimmune kind of vasculitis changes. It will involve the site of nerves and the veins. You should remember, veins, artery and nerve, they go in tandem. Vein is the place where our body, vein followed by an artery followed by a nerve. So this particular autoimmune condition will start involving the nerve and the vein that is there. And as you know, whenever autoimmune condition happens, so inflammation takes place, and this inflammation will anyhow has to heal. And how does it heal? It heals by producing fibrosis, and this fibrosis causes the entrapment of the vessels, that is artery, vein, as well as the nerve. This is an entrance bit. The sharply acute and chronic vasculitis is an entrance bit. Involvement of the small and the medium vessels is an entrance bit. Smoking is a strong predilection for Burgess disease, is an entrance bit. Exclusive disease for men is an entrance bit. There are 5 entrance bits in the last 5 minutes that I had spoken about. So this topic is not something that you should be neglecting. I already told you this encasement takes place. So initially the patient will present to you with claudication. He comes to you with claudication. What is claudication? Claudication is a sharp acute pain, shooting pain in the calves. Okay, sharp acute pain, shooting pain in the calves caused because of ischemia. Okay, so basically claudication is of 4 types. One is Boyd's classification, that's what we call as. Initially the patient will start walking. He has pain, but he continues to walk. Okay, he continues to walk. As he continues to walk, the body will cause vasodilatation, and the substance P that is produced initially, which is causing the pain, is washed away. So this is the first warning sign, but nobody comes to you then. Then the patient will come to intermediate claudication. What intermittent claudication? What happens in intermittent claudication is the patient walks to a certain distance. Okay, he walks certain distance. Pain is there, but he continues to walk with pain. This is Boyd's classification. He continues to walk with pain. The pain is persistent. He continues to walk with the pain, and then in the third stage, what happens is the patient will have to stop. The patient has to stop, take rest, and then walk. This is called as intermittent claudication, and the distance with which pain-free period to a pain period is called as claudication distance. And lastly, the stage 4, where the patient will have pain at rest. And whenever the patient has pain at rest, we are more likely dealing with something called as critical limb ischemia. What is critical limb ischemia? Is, you have to remember, when the ankle brachial pressure index ABI is about less than 1.9. Actually, 0.9 to 1.2 is considered normal ankle brachial pressure index. So how do you check? First you check the pressure at the ankle, then you check the pressure at the arm. You will divide them. If the ratio is 0.9 to 1.2, it is normal. Okay, 0.9 to 1.2 is normal. 0.9 to 0.5 is moderate level of limb ischemia, and anything less than 0.5 is critical limb ischemia. Less than 0.5 of ankle brachial pressure index is considered as critical limb ischemia. So the patient should have rest pain. His blood pressure or his ankle arm pressure index ABPI should be less than 0.5, and he feels comfortable putting the limbs in dependent position. Dependent position is the patient puts his legs hanging, sitting on a bed. That gives him rest, so he wouldn't sleep at all. The patient will have excruciating pain in the calves. Over a period of time, this inflammation process continuously takes place, and the patient will end up initially with ulcer. Once the ulcer state comes, it is imminent that the patient is going to end up with gangrene. So what are the signs and symptoms that the body gives you when you have Burgess disease? The patient will tell you that he has claudication. If the iliac bifurcation is involved, the patient will have impotence. So whenever a case comes to you that is Burgess disease, you have to ask certain questions. That is, number one, pain. What type of pain? Whether the patient is having pain continuously at rest or only on walking, or for a distance he walks and then stops. So whenever you're talking about Burgess disease in your examination, you should remember that you will be asked about claudication distance, rest, pain, and then ankle brachial pressure index. Then these are all the questions that you're going to face. What is critical limb ischemia? These are all the questions that you're going to face. So encasement of the nerve vessel, both the vessels takes place. So the limb continuously becomes ischemic over a period of time. All in the total blockade, the patient will end up in gangrene. But if the patient is smart, he will come to you with intermittent claudication. So what are the questions that you're going to ask? You should be asking the patient about the pain in detail. Whether he had an ulcer that is healing, whether he has an ulcer that isn't healing, that is not healing. It's not healing anymore. This is another question that you should be asking. Then you should be asking the patient about his impotence, because most of the time Burgess disease is the disease of men. So asking impotency should not be a problem. So you should take the lead in asking the patient with this thing. Whenever you have an atherosclerosis process, you should also be asking the patient about loss of hair, decreased sweating. Loss of hair, decreased sweating. Because ischemia is there, the nails become brittle. Brittle nails, dry skin, itchy dry skin, loss of hair, decreased sweat. These are all the signs or all the symptoms that are pertaining to an involvement of arteries or decreased blood supply. You should not be stopping there. You should be also asking the patient if the size of the particular limb is decreased. Because as the blood vessels are getting more entrapped, the blood supply to the muscles decreases. So what do the muscles become? They become shrunken. So there is muscle wasting. Then there is guttering of the veins. You can clearly see veins without blood. The line is there. That is guttering of the blood vessels. That is a sign basically. Then you should be asking about other questions like, does he have chest pain, chest pain, dyspnea on exertion. You should be asking if he has episodes of transient ischemic attack. Now, transient ischemic attack is nothing but a sudden blockage of blood to the brain will lead the patient to fall. I mean, he just goes into blackout or he faints. But over a period, after some time, he gets up and he's normal. He does not know about the event. He just knows that he fell down. He fainted. He does not know anything about. There is no any after effect. That is either you have paralytic stroke. No. Yes, but multiple transient ischemic attacks is a sign for imminent cerebrovascular attack of a bigger proportion. Transient ischemic attack will not produce any after effect or any leftover symptom, long-term symptoms in a patient. But yes, it is a sign of an impending major cerebrovascular attack. So these are the questions that you will be asking the patient in detail. Anyhow, always sleep. If the patient has pain, will he sleep? He wouldn't. So sleep is another important question. You should ask about decreased or increased urine output to know if he is diabetic and that is leading to this thing, or inflammation process is so high that his kidneys are involved and is now producing this. You should know about his diabetic status. You should know about his hypertensive status, but you should know. As you ask, you come well established, and then family history of Burgess disease. Yes, in 30% of the people, positive family history is present in Burgess disease. Then you have to ask the patient in the examination. How do you examine? You should examine the patient in detail. You should look for if he's lost hair, if there is muscle wasting, if more important is check for the pulses. If the pulses are absent, most likely dealing with the Burgess disease. So once this happens, paresthesia is there, pain paresthesia. You should elicit that, pain paresthesia, muscle wasting, attitude of the limb. If the patient is comfortable putting his limbs in dependent position, hanging around without any support down, all these you need to ask. And then you should check for the color change, that is gangrene, if there is any gangrene present. And please remember, Burgess disease is a triad of intermittent claudication. Patient has intermittent claudication as well as superficial skip, or you should call as skipped superficial thrombophlebitis. If thrombophlebitis is there today to one particular vein, tomorrow it will come to some other vein. It won't stay at the same place. Arterial occlusion, intermittent claudication, and skipped thrombophlebitis. These are the 3 points that you should remember in thromboangiitis obliterans. Then, once you establish the diagnosis, the most important investigations that you do is a B-mode ultrasound. You will, in the ultrasound or B-mode ultrasound, you will know the compressibility of the vessel, the flow of the blood column, and the thickness of the vessel wall, or if there is any occult. And then when you do a angiogram, the angiogram finding of a Burgess disease is important because there is a corkscrew shape of collaterals. This is an entrance bit. And there are skipped atherosclerotic lesions. This is also an entrance bit. So as the patient presents, you investigate. Then you have to treat the patient. How are you going to treat the patient? First thing is you ask the patient to stop smoking. If he continues to smoke, you are not going to give any benefit to him even after operating all the major surgeries that we are going to produce. You should give him a choice that your limb is important, or do you want to smoke? I know a patient who said, please cut off the limb, sir. I can't live without smoking. So there are people who would choose smoking over limb. So be prepared to tell them that smoke, finish off your limb, or you stop smoking. There is a chance that we can give for your limb to become better. So you should ask the patient to stop smoking. Then you should give him all the possible superficial thing, that is, you should ask him to wear slippers and walk around, soft slippers. Should always be careful. He should be applying, because the hair loss is there, the sweat is not being produced, so you should keep the moist. So apply moisturizer, and then you give vasodilators. There are 3 vasodilators that we are giving. Previously it was pentoxifillin, before the advent of silastazole. Silastazole we give 100 milligrams BD, lifelong. Pentoxifillin, these are all vasodilators. So we ask the patient, we give pentoxifillin 400 milligrams TID, or silastazole 100 milligrams BD or TID, depending on the patient's height and weight. And then we will ask the patient to something called as the newer drug, that is xanthilol. Okay, this is nothing but it blocks the xanthin oxidase, so thereby not producing any accumulation of the platelets. So you should start the patient with an ecosprin. If the patient is having severely dampened and the pain is at rest, what you can try, your plan is give him something called as lumbar sympathectomy. Lumbar sympathectomy, if you're planning to do a unilateral lumbar sympathectomy, you can sacrifice L1 sympathetic ganglion, L1, L2, L3 and sometimes L4. But if you're planning on both sides, you should spare L1 on one side to prevent sexual activity, to keep the sexual activity or to keep potency there. L1, if single side, L1, L2, L3, sometimes L4. If the options have L4, use it, no problem. When you're doing on both the sides, one side L1 is preserved, L2, L3, L4 is blocked. But at the end of the day, it is only going to give him about 6 to 7 months of pain-free period or symptom-free period or symptom-less period. Again, it comes back. Over a period of time, whatever is there, we will end up doing a below knee or above knee amputation depending on what is happening. So this is in short about Burgess disease. Then there is one small topic that is arteriovenous fistula. Arteriovenous fistula is important because there's one question that is repeatedly asked. Brinham's, what is that sign? Nicolandi-Brinham sign. Okay. What is an arteriovenous fistula? It's an abnormal communication between an artery and a vein. Okay. So what happens in arteriovenous fistula? There is raised blood pressure. There is raised venous pressure. There is raised blood pressure. There is raised venous pressure. There is also raised mean arterial pressure. So there is communication. So the blood is arteries are becoming veins and veins are becoming arteries. But arterial pressure in the arteries is more, so it is more arterialization of veins. So it could be congenital, it could be acquired. It could be congenital, it could be acquired. If it is congenital, you'll have the limb expand in size. If it is acquired, there is no limb expansion, but there is other changes. What is the most discrete thing that you're going to find? You're going to find a thrill in an arteriovenous fistula. You're going to find a thrill in arteriovenous fistula. And this thrill is what we are going to expect. Then thrill is present, increased venous pressure, increased arterial pressure, and mean arterial pressure raised. Then how are you going to find out what's happening? So you will have to see what is happening. Whenever you're suspecting arteriovenous fistula, you should occlude the proximal to the site of fistula formation. Then the pulse and everything will return normal in the distal part. And this sign is called as Nicolandi-Brinham sign. Proximal occlusion of the site of arteriovenous fistula will make everything become normal. So how are you going to treat? You have to treat it by embolization or excision. Embolization or excision. Clear? So that's 50 minutes. The other class will start in another 5-10 minutes. See you all. Have a great time. How do I stop? How do I stop?